This mini lecture is going to be on the herpes viruses as well as viral warts. There are two main types of herpes simplex virus, herpes simplex virus 1 as well as herpes simplex virus 2. With HSV1, it's associated primarily with oral infections, and 2 is usually associated with mainly genital infections. And that is considered a sexually transmitted infection. There are some increasingly common things that have been showing up. So HSV1 genital are becoming more common, as are HSV2 oral, and they think that may be because of the oral genital exposure during sexual contact. The majority of HSV1 and 2 infections are symptomatic, so that only elevated IgG antibody titers show evidence that there has been a previous infection. Both types of these can produce identical patterns of infection, but more than 85% of the people worldwide are HSV1 seropositive, and only 20 to 40% of these individuals do have any history of lesions. So it's real concerning when your partner may not have lesions and doesn't have an actual breakout, but they do have the positivity there. The herpes infections can occur anywhere on your skin. There's two phases. There's a primary infection as well as a secondary or a recurrent infection. During that primary infection, the virus enters the keratinocytes in the epidermis and eventually migrates to the nerve endings. And the virus then ascends via the peripheral nerves to the dorsal root ganglion. And that is where it enters a latent stage without active viral replication. So that can last like for days or for years. And this is why you may not see someone have a breakout. So after each attack, it also re-enters that resting state. There is a trigeminal ganglia, which are the targets of the oral viral strains, and the sacral ganglia are the targets of the genital herpes strains. So the primary attacks of type 1 infections occur in infants and young children, usually mild or subclinically, and type 2 mainly after puberty, and the initial infection is more commonly causes the symptoms. So the majority of them are subclinical and asymptomatic and can be detected only via an elevated IgG antibody titer. In the past several years, it's been recognized that although HSV infection is largely asymptomatic, most transmission does occur during periods of an asymptomatic viral shedding. So when it does lay dormant like that, and that shedding starts to occur, then that's when a lot of the problems can occur. The severity of the viral infection does increase with age, and the herpes infection may markedly compromise nutritional intake in the elderly patient population. It is spread by direct contact with active lesions, saliva, semen, or even cervical secretions, and it can be spread by patients without active disease when the shedding is occurring. The symptoms may occur from 2 to 21 days after exposure. So you may see patients present with tenderness, with pain, some mild paresthesias or burning can occur, and that does occur usually before the onset of the lesion. So many times the patients will say they feel this intense tingling and burning sensation, and the adults usually get this reoccurrence around their lip area. And that is not really known why it does occur there, but that is one of the classic areas for it to occur. So they'll come in and complain that they actually feel a burning and a tingling sensation, and within 1 to 2 days, they see that blister start to come out. Some patients complain that they have a headache, they may have muscle aches, they may get a little bit of fever, and may have some lymphadenopathy on that area as part of that whole prodromal syndrome. After several days, those vesicles start to come out, and they're kind of a grouped vesicle, and they get very like a reddened base to them, followed by those ulcers or the erosions that crust over. There's a loss of the crusting, and the reepithelialization occurs usually within a day or two. And in the moist genital region, though, those crusts may not even form. They may just have exudate that accumulates. The lesions typically heal in about 7 to 10 days without scarring, but they may last up to 6 weeks or longer if they do become secondarily infected with bacteria. So some of the reoccurrences can be triggered by minor trauma to the affected area, other infections, including minor upper respiratory tract infections. Um, Many times patients who have had a lot of sun exposure, that'll bring it out. Hormonal factors in women, so women who are premenstrual, going through their menopause, they may end up seeing this happen. Many women only really realize that their menstrual cycle is coming on because they get a HSV1 breakout. Emotional stress can really trigger these, and you'll find patients that come in and they're stressed out about work or job or a breakup with their significant other, and they'll start developing these. They'll start coming back out. And many times they get triggered if you've had some type of a procedure performed on face. I know that I've seen a couple patients that have had Botox done or Restylane, and they've ended up having some breakouts. So those type of things, just spontaneously occur around that sensory nerve axon to the skin surface and cause those breakouts. So prevention is the key, avoiding the triggers when possible, protecting the lips from sun exposure, making sure that you're wearing lip block on your lips. There is no cure, obviously, for herpes. However, recurrences tend to be milder and of shorter duration than that primary infection is. Therapy is primarily symptomatic and supportive. Nutritional intake is really important, especially in these elderly patients who may benefit from using these anesthetic mouth rinses. The goals for management would be to reduce and eliminate the pain in any of the patient population. When you're thinking about treating these patients, it's usually with the oral antivirals, and we use quite a bit. The initial treatment requires valcyclovir, famciclovir. These have a lot of greater bioavailability and require less frequent daily dosing than acyclovir. The only problem with these is that they are more expensive. So if your patient does not have any insurance and are only paying cash, then you really need to go with the acyclovir versus the other two options. This type of regimen makes these drugs preferable to acyclovir because of that bioavailability. Comfort measures such as warm compresses or doing oatmeal sitz baths does help. And if they have genital or urethral herpes, they may find it easier to urinate in a warm bath water versus just sitting on the toilet to eliminate their urine. Every patient with HSV infection should keep very well hydrated and get a lot of rest. When you're using these medications, there's some specific guidelines to treatment. So with the Zovirax or the acyclovir, that is a medication where it's used much more frequently. So you're using that at least 5 times a day on these patients. If you're using the cream, like sometimes we put the cream around the lips or on the lesions around the lips and not even do an oral, just do that. But you have to put that on 5 times a day. So a lot of times it's just easier to go ahead and do the oral treatment and explain to the patient, you only have to take this one so many times a day versus having to take, that other prescription and keep putting it on throughout the day over and over and over. If they do get recurrence, the topical or the antivirals need to be given, and you may want to think about putting these patients on routine maintenance therapy. So many times we'll go ahead and give them Valtrex just every night at bedtime or an acyclovir every night at bedtime, and that does help with the outbreaks occurring. If they get recurrent herpes labialis on the lips and face, Denavir is also another good option, but that's every 2 hours while you're awake for 4 days. And sometimes patients really have a difficult time putting these ointments and stuff on their lips that frequently. And this is a really good picture of oral labial herpes, and you can see how the lip is swollen, that has that erythematous base with the pustules on it, and how it's starting to get that darkened color. This is very painful for someone who's trying to eat, or in anybody who is um, trying to, eat something with salt. I mean, they'll just go through the roof. But you can also see how this masks the appearance, and people are very uncomfortable with having these on their face. So getting it resolved as quickly as possible is the treatment goal. We need to be educating the patients on making sure they have good hygiene, making sure they understand the risks involved, and that they should ask their partner about any type of exposure or any type of infection that they've had in the past. And make sure, there's times when you just don't know if someone's going to be honest with you, but you need to at least give the patient, tell the patient they have to ask those questions specifically, and hope that the person they're with will be honest about their exposures. So let's shift gears a little bit to herpes zoster, or shingles. And this is an infection by the varicella zoster virus. It occurs along the dermatomal pathways, results in a vesicular skin rash, and especially in those intercostal areas. These are very painful blisters. Um, it is thought that these become latent after the primary infection of chickenpox. It then reactivates, usually in people who are immunocompromised, excuse me. And 1 out of every 3 individuals in the United States will develop shingles at some time in their life. There have been over 1 million cases that have been seen, and this is a very difficult thing for patients to go through. It's very painful. Children may get shingles, but that is usually not the case. But women age 60 and over are at a higher risk than anybody. Half of all of those cases occur young men around 60 years old or over in men and women. It's thought to be caused by immunosuppression that often accompanies the aging process. And immunocompromised patients also have a higher incidence of complications, unfortunately. So what happens with this is that the the same virus that causes chickenpox is responsible for so many different things: the neurological disorders, encephalitis, meningitis, polyneuritis, Ray's syndrome. But the varicella zoster virus initially infects people through the mucosa of the upper respiratory tract or the conjunctiva of the eye. So within a week, the virus has spread throughout the body via the bloodstream. And then about a week later, infection of the capillaries of the skin produced that vesicular lesions of those chickenpox. The virus particles are transported into sensory axons to the dorsal root ganglia, where they lay dormant uh, for the life of the patient. So the virus is most often found in those sensory ganglia of the ophthalmic division of the trigeminal nerve, and in the dorsal root ganglia of the mid to lower spinal cord. If the virus in a ganglion are reactivated, then they replicate, they destroy the ganglion nerve cells, and they migrate through those nerves to the innervated dermatomes, where they produce those skin lesions. So shingles are very infectious, and resulting in chickenpox. So both from the virus and the lesions, and in some instances the nose and the throat. So you have to be very cautious when you're around children who have not had chickenpox yet, an adult who has not had chickenpox in their lifetime, or even pregnant women. You have to be very, very careful about this. Reactivation occurs in a single dermatome, and it usually is one-sided on that thoracic area, so it's unilateral. Usually it does not cross the dermatome of the nerve. So if you have your spine, it's either going to go left or right of your spine, and it can come straight across to the front, but it's not going to cross over that midline. It's a very classic when you see patients come in with that presentation, you know right away they most likely have shingles. So let's talk a little bit about the common clinical features that you're going to see. Initially, that patient may present with unexplained pain. They're not really sure what's going on. They just have pain that's constant, intermittent. It could have a stabbing quality to it. That pain occurs along the involved dermatome, usually 48 to 72 hours before the eruption of a very classic vesicular skin rash. They will tell you that they have itching, they may have tingling, they have that hyperesthesia, they have that severe pain, and it differs among patients. Some patients will say that the pain becomes worse at night or with changes in temperature, and others say it does not. They actually may feel like they're getting the flu. They may feel like they have a headache, that they're feverish, that they have body aches. There may be some lymph node involvement from the drainage in that affected area, so they could have tenderness in the lymph nodes. And within 1 to 3 days of onset of pain, then you're going to see those popping out of those blisters. If the site of infection is along the trigeminal nerve, the lesions will occur on the inside of the mouth and occasionally in the external ear opening. And this, because the lesions are on the eighth cranial nerve, that can cause vertigo as well as hearing loss and ear pain. When it's manifested along the branches of the fifth cranial nerve, then herpes zoster ophthalmicus results, and it gets in the eye. Another major characteristic of the disease is the occurrence of acute neuritis, and that's along the pathway of the rash dermatome. And about 25 to 50% of patients older than 60 get this post-herpetic neuralgia. These new lesions appear for several days. The pain and the symptoms usually start to gradually subside as the eruption disappears. And the rash begins like as an erythemic area, then changes to papular lesions, and then really over that, I'd say maybe that 3 to 5 day span, you'll see them pretty pronounced, and then they'll just start to dissipate. If it's an uncomplicated case, usually 2 to 3 weeks recovery, but in older patients it may take longer, and they may even have those post-herpetic neuralgia symptoms for years and years and years, depending on how bad those nerves have been affected. We think about diagnostic tests. It's usually not really significant, to do them. If the diagnosis is questionable, you could do a polymerase chain reaction assay, which detects the DNA sequence of the virus. But usually you can look at this and you'll know right away what they have. HIV testing for younger adults and patients, if they're getting recurrent outbreaks. If they just have one outbreak, you really don't need to do HIV testing on them. But if they're coming back and this is happening over and over, then that's something that you need to think about. As far as treatment goals, speeding up the resolution of the rash, getting rid of their pain, decreasing their complications. And then antiviral medication is recommended if the patient is immunocompromised and they present within 72 hours of the rash onset if they're over 50 years old. So your principal goals are to manage those healed vesicles, get them pain relief, initial management with these antivirals. So looking at early intervention in the treatment of herpes zoster produces those best results when you're using the famciclovir, the acyclovir, the valacyclovir, systemic corticosteroids such as prednisone, starting at 60 milligrams a day and then tapering over 3 weeks may assist in reducing acute pain, but it has not really been proven to do so. It is best begun within 48 hours of that prodrome, and it's also okay to use it within the 48 hours that vesicle has been present. So the earlier, the better. When we're looking at the treatment, Valtrex is 1 gram 3 times a day for 7 to 10 days, or for 7 days, excuse me. Famvir is 500 milligrams 3 times a day for 7 days, and Zovirax is 800 milligrams 5 times a day for 7 to 10 days. So whether you use the Zovirax oral or the Zovirax cream, it has to be put on 5 times a day for 7 to 10 days. And sometimes that's real hard for patients to be compliant with. And you have to remember, these patients are very uncomfortable. Their pain management can go from mild to severe. You may be able to just treat them with Tylenol or an anti-inflammatory, but then they may also need to have some type of an opioid analgesic or even tramadol. These are very uncomfortable. And many times the symptoms just are excruciating where they can't even stand a sheet on them. They don't want their clothes on. They want to just sit without clothes on, and it's just very uncomfortable. Follow-up is usually not necessary with these patients unless unless they feel that they're not really getting any better. It's essential that anybody with the eye involvement be referred to an ophthalmologist. But other than that, follow-up is not really anything that you need to do with these patients. And this is a very classic example here of how you see how it's following the dermatome of the nerve. So it started most likely near the spine, and it's going anterior under the axillary area, and it will stop midline there. So it could just stay right here. It could go all the way up and down his back, but it will not cross over to the other side of his body. This is a very good picture of what the clustered vesicles look like. When we're looking at herpes zoster ophthalmicus, this is a very dangerous condition that can really cause a lot of problems to your patient. It affects the nerve that controls the facial sensation and the movements in the face. So we're looking at the fifth cranial nerve. And this can cause blindness and requires an immediate referral to an ophthalmologist for evaluation and for treatment. One of the things that I think you need to remember is the key sign to this is a lesion on the tip of the nose. I had shingles around my eye, and I never picked up on this in myself. And I had a lesion right on the tip of my nose, didn't even realize it was there. And I had just a couple little blisters in my scalp, and I felt uncomfortable. I kept popping them, thinking I got bit by something. And here that I saw this lesion in my nose, and within 24 hours, I woke up with my whole eye swollen and red, and luckily I had no lesions inside of my eye. But the key thing was the lesion on the tip of my nose that I never picked up on. This rash appears around the eye, the forehead, the nose. So when I had one little lesion right at the tip of my forehead, and I had 3 lesions like in my temple area. And luckily that's all I had. But that was just enough, and I did not have full-blown shingles around my eye, but it was just enough to cause me problems. And, it's very uncomfortable. The pain was severe. The tearing was horrible. I could not see. I couldn't even keep my eyes open. So I had a lot of photophobia. There was mucus discharge, and my conjunctiva was just hyperemic. I thought it actually felt like I had a brain tumor and someone was trying to pull my brain out of the back of my head. And that's the only way I can describe to you the pain that it was. It just felt like somebody pulling it. As I said, I did not have any vesicles around the eye, so you may or may not see a patient with vesicles, but the symptoms are usually the result of reactivation of that latent zoster infection. And I was under a lot of stress at the time, and that's where that all started coming out. So that latent stuff I had just started brewing. You need to be treated immediately. I went to an ophthalmologist. I was out of town and in Charleston, and I went immediately the next morning to an ophthalmologist. And as soon as he walked in and looked at me, he knew right away what I had and put me on medication immediately. And then I followed up with an ophthalmologist when I got home, but I've never had anything so painful. And I always said to my husband, if this pain is the pain that I'm having, I cannot even imagine if someone has multiple lesions all over their body, on the sides of their body, all the way around the front. I couldn't even imagine the pain somebody would be in. One of the concerns you have to worry about with this is herpetic iritis, and I ended up getting herpetic iritis from it. When they did my really thorough, probably hour and a half eye exam, they did see that I had that. So I had to take eye drops for every 2 hours around the clock. I had to set my alarm, and every 2 hours I had to put those drops in, and I had to do that for 3 weeks. And then I went back, and to this day, and that was 4 years ago, I still have kind of shooting pains in that eye. So your patient may still have some uncomfortable sensations in their eye for a long time after. But when you have this type of thing going on with your patient, you start the treatment immediately and you get them in. And your treatment is the same for this as it would be for herpes zoster on any part of the body, using your famciclovir, your acyclovir, or your valacyclovir. Get them started immediately, call an ophthalmologist, get them an appointment, and get them in as soon as you can. And then we talked just a little bit about the postherpetic neuralgia. Um, this is usually when someone has had the pain for 90 or more days. I will tell you, I right now have a patient, she's 18 years with her postherpetic neuralgia. She sees pain management, and she has never had resolution of this. And it was just a horrible thing because she had a really bad case of shingles and full blown shingles. And so she's had it for years, and that's why I say, it could go away, or you may not have it that long, or you could do just, have like I did, where you just get it every once in a while, you get that stabbing sensation. But the pain can be continuous. There's burning, there's sensitivity. It really alters your lifestyle if you have this for a long time. And many of these patients do need to be put on tricyclic antidepressants or some other type of antidepressant because of the pain. We use a lot of lidocaine patches to that area, topical capsaicin, and they work very well. But there's still a lot of pain that go even using those remedies. We now have two vaccines available for shingles, and in October of 2017, the FDA came out with a new um, shingles vaccine called Shingrix, and it is now preferred over Zostavax. One of the reasons is it's a non-living viral particle, and what it does is it uses just a piece of that virus to stimulate the immune system. So healthy adults from 50 years old and up can get two doses 2 to 6 months apart, and they have to space them apart like that. It is more appropriate for those who are immunocompromised because it is not a non-living viral particle. It contains an adjuvant, which is a substance that boosts the immune system response. And unlike the Zostavax vaccine, you can give this vaccine with the influenza vaccine or the pneumonia vaccine in the same visit. It offers 98% protection in the first year, and that protection remained during the studies. It remained at 85% or higher 3 years after the vaccination. So when we're dosing this, if the patient has not come in for more than 6 months, that has lapsed in between the first dose and the Shingrix, you should administer the second dose as soon as possible. You don't need to restart the vaccine series again. If the second dose was given less than 4 weeks after the first dose, then it should be considered invalid. So a valid second dose should be administered 2 months after the invalid dose. The minimal accepted interval is 4 weeks following the invalid dose. On the other hand, now we have Zostavax, which is a live attenuated varicella zoster virus, and this is the only vaccine we've really had for shingles for many, many years. The FDA approved this for prevention of herpes in immunocompromised adults over 50 years of age. Originally, it was 60 years of age, and then in 2011, they did go ahead and do the approval for it to be over 50 years of age. And the patient history of chickenpox or a serological testing for the varicella immunity is not required prior to giving the vaccine. It is a live virus. It's weakened. So those with significantly weakened immune systems should not receive it, which is one of the reasons why the Shingrix is recommended over and above the Zostavax now. So both vaccines reduce the risk for zoster and postherpetic neuralgia, and the duration of protection is at least for 3 to 4 years, and that's still out on Shingrix. We're thinking it's probably going to be 4 years according to the studies. The need for them to be revaccinated has really not been established, and Zostavax and Pneumovax should not be given concurrently because it can reduce the immunogenicity of the Zostavax, where with Shingrix, you can give it concurrently with that and with influenza. And the studies have been shown that that is effective. If you are giving another live vaccine with the Zostavax, you need to give it on the same day or at least 4 weeks apart. So we're talking an MMR, DP, something like that. It has to be given either that day you give the Zostavax or then give it in 4 weeks. Okay, we're going to switch gears now and go to viral warts and talk a little bit about viral warts, which you're going to see in primary care. And viral warts are tumors. I hate using the word tumors because the minute you say tumor, your patient thinks they have a tumor. But a viral wart is a skin tumor formed by an infected keratinocyte, usually by the HPV virus. They're identified based on their morphology, so it could be a flat wart, it could be a mosaic or a filiform wart, and it also is classified by where it is on the body. These are particularly common in childhood and are spread by direct contact or autoinoculation, and if you scratch them, then they can spread to other parts of the skin. It is a small, when you think about HPV, it's a small double-stranded DNA virus that infects epithelial cells and causes hyperproliferation of these cells. There are at least 150 genetically distinct HPV viruses, but HPV type 1 typically causes plantar warts, whereas type 6 and type 11 cause anogenital warts. There are certain HPV serotypes that also cause anogenital malignancies, including the cervical intraepithelial neoplasms that can occur. So, in general, HPV and the resultant wart can be transmitted by touching, by trauma to the skin tissue, such as from nail biting or shaving. And those plantar warts occur at points of maximum pressure, so usually at the head of that metatarsal bone in the heel. The anogenital warts are usually sexually transmitted, but the route of transmission does not necessarily have to include penetrative intercourse. It can be due to genital contact or heavy petting. Warts have a hard warty or a verrucous type of appearance to them. The infected keratinocytes form a mass that really kind of is confirmed to the dermis. And a common misconception is that they have roots. They do not have roots. In reality, the underside of the wart is usually very smooth and round. And although that wart appears to infiltrate the dermis and the subcutaneous layers, it's usually limited to the epidermis only. There's also black dots that can be seen on the surface of a common wart, and those are, some people say they're infection, but they're not. They are thrombosed capillaries, and that they become trapped in the cylindrical finger-like projections. So you'll see common warts arise most often on the back of the fingers or the toes, and even on the knees sometimes, and those plantar warts are on the sole of the foot. Plain or flat warts can be very numerous and may be inoculated by shaving, and the periungual warts are the warts that you'll see under the nails, and they can actually distort your nail growth and cause some difficulties with that. Warts are sometimes they can be isolated, they can be clustered together, they form like a cauliflower type of appearance to them. But flat warts are small, they're slightly elevated, they have like a flat top papule, and they're usually numerous, and they may be on the forehead or the mouth, the beard, the eyes, or the back of the hands. The cutaneous HPV infections, so you're looking at type 1, 2, 4, and 7, are most likely to be seen in children and young adults and have an incubation period of 2 to 6 months. As an individual gets into adulthood, then those presence of those cutaneous warts really start to decrease significantly. The genital warts are often transmitted sexually, and they predispose to cervical as well as penile and vulval cancer. So treatment, it's important to remember that most HPV lesions resolve without treatment. Therefore, initial management really is geared toward relieving the pain and the pressure and minimizing any type of skin trauma and scarring. Therapy is usually individualized because you have to look at some of the unwanted effects such as pain, hyperpigmentation. Are they going to scar? Are they going to have damage to the normal tissue? Are they pregnant? Is the woman pregnant because of the potential harm for a lot of these treatments with pregnancy? The treatment usually ranges anywhere from 1 to 2 weeks, but you never know how much longer you're going to need to do that. You can also cover warts with silver duct tape for 6 days at a time and uncover the wart, and that's debriding it as you go. So you do an emery board or a pumice stone and you cover it back up again, and then you repeat that cycle and see if it goes away. It's a very inexpensive treatment, and you can use it for first line treatment also. There's keratolytic therapy in the form of salicylic acid plasters, so Mediplast, Duoplant, Occlusol. Those are very safe, non-scarring, moderately effective, low-cost over-the-counter treatments. Once the wart's paired with a number 15 scalpel blade, though, or a pumice stone or an emery board, then you soak it, you soften it, and you facilitate the penetration with that solution. The surface needs to be dried, and then you put an adhesive tape or bandage on top of that. Tape occlusion can precipitate the inflammation and the soreness and may necessitate you having to interrupt the patient treatment for a little while to give it time to ease up some of that discomfort. There are treatments including retinoid, such as your Retin A that you use. There's 5-uracil, 5% cream that you can put on. So there's a lot of different treatments that you can use. Podophyllin resin is a compound tincture of benzoin used for external warts. And then surgery, cryotherapy surgery, cryosurgery is effective for common and genital warts, and it depends. Usually a gynecologist may do this, or a general surgeon might do this. There's also light application of liquid nitrogen, which can be used, and that is something that you can think about doing. So there's a lot of different treatments for warts depending on the kind of wart it is and how you can describe that wart and what stage that is. When you're thinking about dysplastic cervical lesions, you're looking at stage 2 and 3, where they would do cryotherapy, where the lesions would be frozen, and usually your GYN would be performing that. And this is a very classic picture of a common wart on someone's thumb, and you can see how that appearance is, where the top is hard and crusty and elevated. And as I said, the plantar warts, you can do the over-the-counter salicylic acid. Usually these patients are not needed to be coming back for follow-up unless there's not any type of resolution. And if you can't get it to resolve or they can't get it to resolve, then you can refer them to dermatology. I don't usually do anything on the face because they're difficult to remove and they can leave scars, and you'll see sometimes flat warts on the face. But I refer them to dermatology when it comes to the face because I don't want to risk scarring the patient for any reason. And then this is a very classic picture of a plantar's wart. You can see how it's right on the heel of the foot, and you see that black center there, which is that hyperpigmented area, that hyperkeratinic area. And a lot of patients will think they can dig, so they'll go in and they'll dig and they'll dig and they'll dig and try to get that out. Once they get that black dot out, it'll go away. But usually this needs to be removed by a podiatrist. And these are some other pictures of plantar warts on the feet.